I assume I wasn't meant to do that.
Not to worry.
I told you I'm not good with IT. So you still can't see my screen?
No, we can now. Just to let you know that everyone who's online can now see and hear us.
Okay, I'll pretend the kids are listening then.
So yeah, let's just get your
to
slide deck ready. Just to ensure too that there's no images with they've been de-identified, Tom, any images that you're showing?
Yeah, everything's been de-identified.
Brilliant, thank you. Okay.
Okay.
We can't hear your audio, Suresh.
Yeah. So that's it, Tom. Now you can just scroll through it like you would do a normal presentation.
Okay.
Yeah, and
yep, we can see that.
And you can either keep your camera on during the lecture or turn it off. It's entirely up to you.
If I knew how to turn it off, I would.
There's a little, there you go.
Yeah, I got it.
Okay.
So
what we might do, Suresh, is maybe just, oh, sorry, you were going to say something?
No, I was going to say, I was going to introduce Tom. I've had a little problem with my daughter. Put it this way, it's the go feral at 6 o'clock, young girls traits, and she's taken my mobile. So what I might get you to do, Trent, do you actually, oh, actually, no, I know what to do. I know what to do. Let me see if I can bring it up.
I've got Tom's bio in front of me, if that's what you're going
to
ask
you?
me.
Yeah, that's what I was going to ask for. Let me.
Do you want to turn your camera off, Suresh, because everyone who's on the call can see? And just coming back to your good self, Tom, so I can also see on your screen all of your icons down the very bottom on your Mac.
Yep.
Are you able to hide those for us, please? And could you also just make sure that you don't have any applications open, like, I don't know, any emails that may accidentally have, pop-up messages that appear during your session? If you can just close those off for us as well, please.
Trent, would it be okay if you introduced Tom?
Absolutely, that's fine.
Yeah. So I'll get you to introduce Tom and then just hand over to me and I'll just say a few quick words about the collaboration that we have with our games.
Okay, sounds good. So those icons are still on that screen, Tom, if you can find a way to just, yeah, there we go, perfect, thank you.
I assume you don't see the control panel from the webinar stuck on the right-hand side of the screen?
We can't see that.
No, we can't see that, Tom. So the only thing we can see now is your lecture, Simple Approach to Liver Lesions.
Yep.
That's all we can see.
Oh, good. Let's leave it at that.
Yeah. And so as you scroll, that's all they'll see. If you turn your camera on, they'll see the camera and they'll see you. It's probably nice at the start to have your camera on before you start your lecture, so as we introduce you. Then it's entirely up to you. And apart from that, really, you just run through your lecture. And Trent and I and Catherine will keep an eye on the questions. And we'll take the questions at the very end. Sometimes there may be a very pressing question depending on what you just said at the time. And occasionally we may just stop and ask you the question at the time. But usually we leave questions till the very end.
Yeah.
So you'll find, I mean, apart from, little glitches, little minor glitches, the platform runs it's pretty robust. And for example, on Saturday, we had an MSK conference and we were able to have 640 delegates dial into that without it crashing. So it's pretty good. Yeah, pretty good. So
I assume it's okay. I've plugged in my Precision Philips speech mic thing.
Yeah, that sounds fine. That sounds good. Thank you, by the way, for delivering this lecture.
That's right. Thanks for the opportunity.
And nice to meet you in person as well. So I've been in contact quite a bit with Richard Mendelsohn over the last 2 years because he's doing quite a lot of work now for the charity.
Yeah.
And Kirsten did the 2 collaborative lectures last year and the year before. So it's nice to develop this ARGANS partnership more and more. So appreciate it.
Yeah, well, I mean, it completely fits with the goals of ARGANS when Richard set it up, and it's a great cause to be involved with. So it's good collaboration.
Yes, thanks. Yeah. So next year we're actually for the charity. We have is that Catherine?
It is indeed. How are you?
Hi, Catherine. How are you?
Not bad, thanks.
Catherine, just to make
Hiding
mention,
away from COVID down here.
hi Catherine, it's Trent. Sorry to interrupt. I'm just going to say, just to make mention that we've actually started the broadcast. It was an accident. So just to let you know that what we're saying, the other participants can all hear.
Okay.
So Catherine, what was I going to say? It's okay. I might do the Q&A today. Then the next session.
Happy for anything, Suresh. I'll just monitor the questions in case something urgent crops up or needs a tech answer or something.
Yes, thank you. And for the next one with Rudiger, it's probably best if you introduce Rudiger and do the Q&A because it's a neurology session, as you know. So
very happy to do that. I invited him out for ANZ SNR a few years ago, and he's an excellent speaker.
Yes, no, I'm looking forward to hearing Rudiger's talk as well.
Apart from being one of the leading neuroradiologists for stroke in Europe and centre for most of the trials.
Yeah, terrific. So Tom, I was just saying that next year in 2022, we're doing another abdominal virtual conference, and Richard's involved in that, and so is Kirsten. They're both doing lectures for that. And I think one of Richard's pet topics is contrast enhanced ultrasound. And he makes a very valid point. That's a really useful modality for a lot of the nations that we go to. So we're actually going to have a separate virtual conference on that as well, purely on contrast enhanced ultrasound. And the lecturers include probably colleagues that you know. I have to say I've been so busy with RAB, I've sort of kept out of circles, but there's a Peter Simpkin. And yeah, is that right? And Rob Gibson? Is it Rob Gibson?
Yeah, Paul Simpkin, he's at RMH with Rob Gibson. He's the, I think as Rob winds down, Paul's taking everything over and doing a great job.
Yeah, so that's another thing we were going to do. But this is all.
He's an excellent teacher too.
Sorry, what was that, Catherine?
Rob Gibson's an excellent teacher. He taught me as an undergraduate.
Right.
And as a radiology registrar. I know him reasonably well. He's excellent.
Right.
Yeah, listening to Rob made me want to start doing contrast ultrasound. He explains it so well.
Yeah, so that's another abdominal session we'll do next year. We were planning to do the first ARGANS collaboration site visit, and we had it all planned for Cambodia last year. So it was going to be, I think there were going to be 2 or 3 from ARGANS and 3 from RAB. So we do that also with AMSIG. So we have a musculoskeletal collaborative site visit each year when we've done 2 of those. So hopefully when we can get COVID under control, or a bit better under control, we can start thinking about doing the inaugural visit again. So probably in 2023.
Yeah, and Josh was trying to organise a fundraising ARGANS fun run at some stage for RAB.
Yeah, I know. He loves his running, doesn't he, Jash? So,
he does.
Yeah. Jash is great. He's done a few trips for us. He's been to Mongolia, Fiji. He's been to one other site too. So no, he's good value. So you've got a big registration. So you've had 640. We call it sites because a lot of obviously the majority are single people, but in a lot of the developing nations there are multiple people. For example, in one of the 2 of the Asian nations, we've set up teleconference rooms, and I know in Fiji they have a teleconference room, and it's the same for a lot of different places. So you'll have a big audience. Now, normally we get that 640 converts to a conversion rate around 60% attendees, but still that will be a very big audience.
Yeah.
And
yeah, it's bigger than you get for an abdo session at the college meeting.
Is it? I have to say, I'm looking forward to getting back into some, coming back to some ARGANS meetings. But what are the attendances like there in terms of you had a virtual conference this year, didn't you?
Yeah, so I think we managed to hit 400 delegates this year.
That's good.
We did there was a COVID outbreak on the Saturday of the meeting. So a lot of the locals in Brisbane didn't turn up on the Sunday if they were from the Sunshine Coast because they didn't want to have to isolate. But yeah, I think the virtual meetings has helped numbers to a degree, but it's just not the same social interaction and those chats in the breaks where you get to talk to people and find out what they're doing. I miss those bits. It's often the most useful component.
Yeah, true. Look, the virtual conferences have really helped us because instead of delivering, a site visit lecture series in one country, we're now able to connect with multiple countries. But you're right, the personal contact is definitely not there. But there has been, I guess, we've been able to reach a lot of countries. Like the MSK session we had on Saturday reached 50 nations. So, I guess there are some benefits. But do you think that once next year you'll be going to a hybrid, or will you just have a pure in-person?
I think the pure in-person is just so appealing these days. It's never the same.
It's interesting. BSNR, the British Neuroradiology Society have gone straight to a full-on in-person meeting in a couple of weeks' time with no virtual at all.
That's pretty brave with the number of COVID cases in England at the moment, isn't it?
Well, it shares in London as well. And I think they've just given up on the virtual meetings because it's all too much. They've got some good 1-hour sessions, but they're that sick of not getting together, and there's so much COVID. Well, what have they got to lose? Because they're going to get it anywhere, whether they go or not. It's so rampant. There's probably no increased risk of being in person.
Yeah, probably true. But it's interesting times. It's sort of recycling there, isn't it, with the COVID though at the moment?
It is, because once you get to 4 months, the effectiveness of the Pfizer and the AstraZeneca vaccines both start to wane.
Yeah.
And because the UK got in and vaccinated early, a lot of people now are getting COVID again or getting exposed to it when they were okay before, because the vaccination's waning off, which is why everyone over 50, anyone who's clinically vulnerable, and anyone in frontline jobs is now being offered a third dose. I think all of mRNA vaccines in the UK now, they're not even thinking about, because the numbers are going up so much. And the deaths are going up as well, not as much as last year, but the deaths are still increasing. Interestingly, I was speaking to a friend, and 20% of all patients in ICU are unvaccinated pregnant women, and 1/3 of all patients on ECMO in the UK are unvaccinated pregnant women.
Right.
And that's scary.
That's a difficult cohort, isn't it? Because of I read it because of the effect on the lungs, isn't it, of the COVID with the pregnancy, the combined problem with the pregnancy and then COVID on top of that.
But anyone who says COVID's nothing to worry about needs their head read. It's also a top 10 cause of death of children in the States now.
When you say children, what age group are you referring to?
I think this is the under 12s who haven't been vaccinated in the States yet.
I read that the states are looking at, are they trialing it, Catherine, or they are bringing it in for children as young as 5 or 6? Am I right in what I read? Perhaps?
FDA's just approved the Pfizer vaccine for
Pfizer.
5 to 11-year-olds.
And
that's what, and based on that, they're talking about giving it to our children from the end of November.
What are your thoughts as clinical people? What are your thoughts?
Sorry, Catherine, has it been approved by the FDA or just submitted to the FDA?
It's just been approved.
Approved. Okay. Trent, can I ask you the video that we have made for Tom, just the introductory 20, 30 seconds, can we still run that?
I'll have a look.
Wow, you made a video.
Oh, it's just literally 20 seconds. You'll see. It's a little futuristic 20-second introduction on Tom Sutherland. It's very basic.
To do that, I'm going to have to take back presenter mode from Tom.
Yeah, why don't you do that, and then we'll give it back to Tom once we get started.
You got too much time on your hands.
I'm not seeing the video though in the drop downs and the handouts.
Let me just get Steve on the line. I'll be 1 tick.
I was just going to ask you, Catherine, what's your professional opinion around children of that age? Do you think from a clinical perspective to be having...
I think everyone needs to get vaccinated. This is a highly dangerous disease at any age. And while it might be killing more older people, if it's one of the top 10 causes of death in children in the States, again, it will be in an unvaccinated population. As our Premier says, this is a pandemic of the unvaccinated. Vaccines aren't perfect, but the more people who get vaccinated, the safer we all are, including the children. If it's one of the top 10 causes, that's a serious issue.
Mm.
So it's the children primarily need help, but it's also their grandparents and their parents if they're clinically vulnerable. Because if you've got a child that's infected, they go to visit their grandparents and their vaccination's waning, there's a chance they could infect and kill their grandparents, and that would be a dreadful thing for anyone.
Yeah.
So I think that's another thing to think about, is the effect if you end up killing your nearest and dearest because you're not vaccinated. I know it's not deliberate, but you still feel bad about it when you could have done something.
Yeah. Not sure where Suresh has gone.
When do you want to start?
Absolutely. Let's start now. I've got the video. I can see it now.
Just have Steve online, so he's just going to try and get the video going, and then we'll get started.
Oh, he's about to do it now.
I'm not sure if that happened, or we might get started. I'm not sure if I think the
that did come through.
Yeah, but it wasn't the actual video. But that's okay. Let's get started, so we won't delay it any further. So I'll hand over to you, Trent, to do the introductions.
Okay. So hello everyone and welcome. We different view of starting today's webinar, but I hope you've been able to enjoy some of the conversations that we've been having with everyone online. So welcome to today's presentation on the simple approach to liver lesions. This is going to be presented by Associate Professor Tom Sutherland, who you can see on the webcam now. Tom is the present chair of the Peak Abdominal Imaging Group, the Abdominal Radiology Group of Australia and New Zealand. He is a general and abdominal radiologist at St Vincent's Hospital in Melbourne. His primary interests are and I'm not going to be able to say that word, Tom, so you might have to pronounce that for me, but genitourinary and hepatobiliary imaging.
Yes,
I apologise. Thank you kindly. It's almost another language there. But in particular with the prostate MRI and ultrasound contrast examinations. He's also has a growing interest in post-mortem CT after spending 6 months at the Victorian Institute of Forensic Medicine. He has a passion for education and has a graduate diploma in clinical education from the University of Melbourne. He is also an associate editor of JMIRO and an abdominal examiner for RANSCAR and has served on the ARG ANZ executive since 2013. So I'd like to welcome Tom, Associate Professor Tom, to this evening's presentation. Before we hand over to Tom though, just for those of you that have joined Radiology Across Borders for the first time, we welcome you. And for those that are returning, thank you for being online for today's session. If you are new to this platform, We do encourage you to ask questions throughout the presentation. We will be monitoring the question area. If you have a look on your screen under where it says chat, that is where you can enter in your questions, and these will be fielded by Tom and the team later on. So I'll just quickly hand over to Suresh De Silva just to say a quick few words. Thank you.
Thanks, Trent. Look, I'll just say, just very quickly, welcome everyone to the session today. This is a very important session that we have now where we run every year, which is our collaborative session with ARGANS. So for those of you who haven't heard of ARGANS, being a global lecture series, ARGANS is the peak body for abdominal imaging in Australia and New Zealand, which was founded by Professor Richard Mendelsohn quite a few years ago and has grown to be the peak body in this space in Australia and New Zealand. They're collaborating with us through the lecture series, and this is the third one they're delivering. And when we get the site visits going again, hopefully either at the end of 2022 or start of 2023, we'll be hoping to do a collaborative session with ARGANS in one of your nations. So a very special thank you to ARGANS, and a particular thank you to Associate Professor Tom Sutherland, the chair of ARGANS presently, for delivering the lecture today. So as indicated, please put your questions in. Just one addition, if you want to verbalize your questions, just remember that you can put your hand up. There's a hands up option, and you can verbalize your questions either during the lecture or towards the end. So please keep those questions coming through, and we look forward to addressing those at the end of the session. So sit back and enjoy.
Look, thanks for the introduction, and RAB is a great cause and something ARGANS is probably happy to continue collaborating with into the future. I was going to talk about a simple approach to liver lesions. This is an approach that I've developed over the last decade or so, largely because when I started liver imaging, there was no abdominal radiologist at my hospital other than 1 day a week. And so I made an enormous number of mistakes. I got a lot of feedback, and I've learnt over the years, and this is the approach I've developed to minimize the mistakes that I make. And the reality is liver imaging has a bit of a reputation for being something that's relatively complex, although we're all expected to do it. We need to propagate the myth that it's complex to hepatobiliary surgeons and gastroenterologists, so they realise how dependent they are upon us. But amongst ourselves, we can acknowledge that we can have an approach that does make it simple. I've got a couple of disclosures, and really the objective here is to have a simple approach to answer the question of what's that focal liver lesion. So I've broken it down into a couple of steps. A lot of the talk is going to be about MRI, but that can also be extrapolated to CT, and then there's a bit about ultrasound as well. And the basic ideas are really independent upon modality. But obviously the first step is making sure you've got the right tests that you're doing. And then when you've decided that it is an MR that you're going to do, you have to make sure you've got the right contrast agent. And these days we're quite lucky in that we've got two agents we can use. We've got the hepatobiliary agents, which is Primavist, and that gives you all the dynamic information of your arterial, your portal venous phases, but it also gives you functional information by having that hepatobiliary phase and seeing how the hepatocytes are taking up the contrast. You can also use the non-hepatocellular agents. The reality is, these days we would use Primavist for about 95% of the cases that we do. And in part, that's because of our patient population. I like to use it anytime we have a patient with chronic liver disease. I think it gives you a lot more information about the actual nodules that you're trying to characterize. We know that in patients who have colorectal carcinoma, the hepatobiliary phase and diffusion increases your ability to detect lesions and characterize them, and it reduces the rates of early disease recurrence post-hepatectomy, which isn't really disease recurrence, it's disease that was there beforehand that wasn't detected. And we all know that Primavist is vital to be able to differentiate FNH from adenoma. The times that I don't like using Primavist is if it's something like a Klatskin tumor. I prefer just to use a normal agent. You can get that delayed phase enhancement, and I think it's a bit better at seeing the arteries. And also if you've got a small hemangioma, I don't give Primavist. Often, unfortunately, in the clinical notes, you've got no idea what they're really looking for, and you may not have any previous imaging. And in those cases, you can just get the text to run a quick T2 through the liver. And if it's looking light bulb bright and you think it's going to be a hemangioma, I'll give Gatavist. If I can't see anything, I will then go on and give Primavist, and that can occasionally get you out of trouble. And this is why I like to avoid hepatobiliary agents if it is a flash filling hemangioma or just a small hemangioma. You can see on the screen here on the left, this is the unenhanced MRT1, and on the top it's Primavist. And you've got this hypoenhancing lesion. You don't really appreciate the peripheral nodular enhancement because the background liver is enhancing quite quickly. And in the hepatobiliary phase, it's dark because there's no hepatocytes within it. And in these cases, even though you can see that it's bright on T2, I think giving the Primavist just reduces your confidence and increases your overall anxiety. And this is the same patient having a study without Primavist. This was Gatavist at the bottom, and you can appreciate that peripheral nodular enhancement and the progressive enhancement in it. And it just gives you a better diagnostic confidence. So step 1 is choosing your contrast agent, and step 2 is know your background liver. And I think this is a step that a lot of people skip. When we're all learning radiology, you get books like Chapman that just list lesions, for example, hypoechoic versus echogenic in the liver. And what those books never state is that is relative to a normal background liver. So the first step is your background liver normal? Because that's going to dictate what each lesion looks like on each sequence and what it looks like on your ultrasound and your CT. So with MR, we've got the opposed phase at the top and the corresponding in phase at the bottom. This is the normal thing. You get that India ink around the peripheral aspect, anywhere you get soft tissue and a fat interface. So you can identify it as the opposed phase. And on the in phase, the signal intensity is about the same. So you have a normal background liver. Here we have dramatic signal loss within the liver on the opposed phase. So that is a steatotic liver. And in this example, we've got low signal to start with on the opposed phase, and we lose even more signal on the in phase. You've also lost signal in the spleen, and this is iron deposition. So this is really important because if you've got a fatty liver and you do a fat saturated image, the lesion is automatically going to look brighter because you've suppressed the background. And fatty liver is exceedingly common. So there's basically an epidemic of fatty liver going on. It was a couple of years ago that I think we finally hit the point where there are more overweight people in the world than malnourished people. It is definitely increasing. And there's a subset of patients with non-alcoholic fatty liver disease who get associated inflammation with it, and that is NASH. So NAFLD is just steatosis. NASH is steatosis with inflammation. And there's multiple causes of it. There's alcohol. The main thing really comes down to metabolic syndrome, overeating. It's part of the obesity epidemic. You also get it in patients who are on chemotherapy, and steroids can do it. So you'll often get it in patients who have autoimmune disease as well. And it is really important to recognize. We probably get one young patient a year who is told they have inoperable metastatic disease to the liver, and it's really FNH on a background of steatosis, so they look relatively hypoechoic, and that just causes an enormous amount of anxiety. And it's just failing to recognize the background liver is abnormal. It is a worldwide disease. It does vary a bit depending on where you are, but many places do have a prevalence of around 30%. So almost if in doubt, does this patient have fatty liver? There's a high probability that they do by the time they've come into your practice, because these patients do tend to be sicker anyway and seek more imaging. The natural history is that it's a risk factor for cirrhosis. There are many factors that can predict your likelihood to go on. So central obesity is worse. All of the metabolic syndromes are worse. Dyslipidemia and type 2 diabetes. Unfortunately, with imaging, we cannot differentiate NAFLD from NASH. We can simply say they have a fatty liver, and it's up to the biochemical and the clinical aspects to work out what their risk of inflammation is. But from our point of view, it's important to point out that it is present, and also to recognize that it's going to alter how you view the focal liver lesion within these patients.
So if you've got NAFLD, there's up to a 30% chance you will have inflammation and NASH. If you've got NASH, up to a 40% chance you'll develop fibrosis. And so this is going to be the leading cause of chronic liver disease and fibrosis in many of our communities. So this is Australian data, and we've got around population of around, I think, 25 million at the moment. So there's around 200,000 patients with Hep B, 300,000 with Hep C, but fatty liver is around 5 to 6 million people in Australia. Now, the numbers here with asterisks are my calculations. So if we've got 5.5 million people NAFLD, that's around 1.1 million who have NASH. Then you've got about 300,000 who have fibrosis and over 100,000 who go on to get cirrhosis. So this is the leading cause in many countries. Although this is really focused on the liver, most of these patients are not going to die of liver disease. You need to think of NASH as a marker of ectopic fat accumulation and inflammation. And most of these patients die of cardiovascular disease. They have strokes and heart attacks. The relative risk is around 3.5 times if you have NASH of having an AMI or a stroke. So this is something that gastroenterologists are aware of, stroke physicians and cardiologists, but many other specialties aren't. GPs are coming on board and learning more about it. But as radiologists, I think we do need to point out that this is an important condition and it really is a systemic problem. Fortunately, they do have slightly lower rates of getting an HCC compared to Hep C related cirrhosis, but simply because of how common it is, it's really going to swamp our practices. So many of these patients will present with ultrasound, and all of us have reported ultrasounds and have a bit of a guess, is it echogenic or not when you're looking at the liver? And there are ways that people try to compare. So often it's comparing it to the right kidney. Someone sent in a question asking if the first image you get of a liver should involve that right kidney. I'm not fussed as long as you do acquire it. And when you're characterizing the lesion, make sure you've gone back to that to work out is the liver fatty or not. It is very subjective though. I think if the liver is mildly echogenic compared to the kidney, I will give them mild steatosis. You have echogenic walls next to the portal vein. When those start to get obscured, because the background liver is getting bright, I call that moderate steatosis. As soon as you get focal fatty sparing adjacent to the gallbladder bed or the porta hepatis, I'll call that moderate to severe steatosis. And then when you get a really echogenic and attenuation of the beam, so you can't get that deep penetration to the liver, that becomes severe steatosis. So just a simple grading system, probably doesn't have a fantastic kappa, but it seems to work reasonably well. And as I said, if in doubt, chances are they have it anyway, particularly if they have a long skin to liver distance. But this group tried to do something a bit more scientific. So they put a region of interest over the renal cortex and over the liver at the same depth, and it did have a very good correlation. The reality is we don't do anything like this. We just use the simple grading system, but it did surprise me that this didn't catch on more. So knowing your liver is really important. Every now and then you get cases that do cause a bit of concern. So this is another liver MR. So we've got our pre-contrast here, and there's this focal liver lesion. This is with Primavist, and one of the problems with Primavist is, particularly if you inject it quickly, patients get a transient dyspnea, so the arterial phase is often relatively poor, but this is hypoenhancing. It remains hypoenhancing in the portal venous phase. So everything about this was looking like a metastasis. But this is the hepatobiliary phase, and the lesion is iso-intense to the background liver. And I saw this case about 10 years ago, and it did throw me because I thought this must have functioning hepatocytes within it because it's iso-intense, but it looks like a metastasis. It doesn't make sense. And then it started my next lesson, which is on the pre-contrast, I always compare the liver to the pancreas. And the pancreas should be much brighter than the liver because it's got a lot of proteinaceous material within it. Often patients who have a bit of chronic pancreatitis, it is a bit darker, but it does provide a really good internal reference to compare it to the liver. In the hepatobiliary phase, the liver should have taken up so much contrast that it should be much brighter than the pancreas. But in this case, the pancreas is just as bright as the liver. So we basically don't have any uptake. So the hepatobiliary phase is completely unreliable. It is simply a really, really delayed phase without being hepatobiliary. So this isn't functioning hepatocytes at all. It's just a liver that doesn't take up the contrast, and this was a metastasis. And there is a group of patients out there who don't have the cell membrane transport protein to take up the contrast. We know patients who have chronic liver disease, as their disease deteriorates, they tend to take up less contrast as well. So it's just a good check every time you look at the hepatobiliary phase, compare the liver to the pancreas, how much have they taken up, and that will dictate what your focal liver lesions look like. If you want to exaggerate the amount of contrast that you've got in your liver, on the hepatobiliary phase, you can also do just increase the flip angle to around 35, and it really does make the contrast pop, and you get a lot more bang for your buck. That can be quite helpful. We will still do a hepatobiliary phase with a flip angle of 10 degrees, just in case we want to do a subtraction, and then we do a second one with a flip angle of 35. So starting with chronic liver disease, we all remember that the liver has its dual blood supplies, around 75% from the portal vein, and the rest is arterial. So as your lesions progress, so fibrosis causes, you get cell death, cell regeneration, they accumulate mutations. So it's a progression from a low-grade dysplastic nodule to a high-grade dysplastic nodule. Then somewhere in that nodule, you develop a little HCC that will eventually grow and take over the nodule and become a well-differentiated HCC before dedifferentiating. And as it goes along that pathway, it tends to lose its portal venous inflow and increase its hepatic arterial inflow. And this is why we do the multi-phase CTs, to try to show that arterial hyperenhancement and then the washout later on. So it's really important when we're doing our reports that we all speak the same language. The LIRADS group has put a significant amount of work into having a glossary. It's quite long, but I suggest you do look at it. You can also get, I think this through the ARGANS website, and ARGANS has endorsed the glossary. So people talk about the late arterial phase or the arterial dominant phase, and this is really how we want to image the liver. You want contrast in the hepatic artery, and you want contrast in the portal vein, but not in the hepatic veins. And if you fire too early and you're just getting arterial contrast and none in the portal vein, you haven't given your liver lesions a chance to hyperenhance, and you won't see them. So whenever you're looking at the arterial phase, make sure it's contrast in the artery, contrast in the portal vein. You then know it's adequate quality, and then you can look at the rest of the liver. Arterial phase hyperenhancement is when your lesion is brighter than the background liver. And it's really important to recognize that washout is when those lesions become darker than the background liver in the portal venous or the delayed phase. If you're using Primavist, you don't get a delayed phase, you're getting a transition phase because the background liver is starting to enhance. So washout is not a Primavist feature after the portal venous phase. Fading is more of a benign feature, and that's when the liver lesion drops back to being iso-intense or iso-enhancing to the background liver. So these terms are both MR and CT. So good quality images are really important. This patient on the top picture here, you can see you've got a focal liver lesion here. There's no arterial enhancement within it, but we've got contrast in the arteries. There's some in the renal vein, but there's none in the portal vein. This is the same patient. Again, it's not even fantastic enhancement here in the portal vein, but we're getting some, and you're starting to appreciate that there is some arterial enhancement within there. So this is simply shot too early. And again, with this patient, contrast in the arteries, very dense, nothing in the portal veins you can see in the liver. Same level, contrast in the arteries, contrast in the portal vein, you can now appreciate you've got this arterially hyper-enhancing lesion. And it really is important because I've seen multiple studies done where it's been said this is not an HCC because it's not arterialized and it's simply shot too early. I've also seen studies where they've said this is not an HCC because it's smaller than a previous study, and that's simply that the second study fired a bit earlier, and so the lesion hasn't enhanced as much and looked smaller. So really do critique the quality of your pictures. And HCC is a tumour that we do really need to take seriously, not only because it's relatively common and is also relatively fatal, but because it's also the only tumour that people will treat based upon our reports. Pretty well every other tumour, if the patient's going to get chemo, the oncologists demand a biopsy first. With this, if we call it, the patient may well get an ablation, a resection, chemoembolization, or even a transplant based simply upon our report. So we do need to be incredibly specific and confident when we do this. And the two main features that you have to look for are arterialization in the arterial dominant phase and washout. So here we can see this lesion is arterialized. It is becoming darker centrally to the background liver, and again, darker centrally to the background liver, the impression of a little capsule around it, and it's dark in the hepatobiliary phase. You don't need this to make the diagnosis of HCC, but it does show you that these cells are functioning to a lower degree than the background liver. But you can make the diagnosis simply on arterial hyperenhancement and washout. Then, of course, you get lesions that don't quite behave like that. Here, it's iso-intense on the pre-contrast, arterial hyperenhancing, but it's faded. There's no washout at all, yet it's become dark in the hepatobiliary phase. You can't call this an HCC based upon most of the guidelines, but we do know that it is behaving abnormally. It's dropping its portal venous inflow, it's recruiting arteries, and these cells are dysplastic. This is likely an early HCC anyway. Even if it isn't, chances are it's going to become an HCC within the next 12 months. But you can't be as definitive because you don't want this patient getting a transplant based upon it. These are patients who should be referred to an MDM for ongoing discussion and management. Other signs that you can look for that are going to increase your diagnostic confidence. I've always liked nodule in nodule simply because I think it shows the natural history, because you have your dysplastic nodule and one of the cells in it becomes an HCC and slowly takes over. So you can see that here on the right image. This is a coronal. You've got this entire nodule here, but only the inferior half of it at this stage is arterialized, but that's the entire nodule. So it's a dysplastic nodule and this is the HCC within it. That's a very good sign. Fat, which you've got here, and I think that was another, that was also arterialized, that component that didn't have the fat within. And there's not that many focal liver lesions that do have fat. It's really HCC and adenomas are the two main ones that you can come across. Having a capsule is also a very good sign of an HCC. I'll put this picture in twice because I must really like it. You can tell that this patient has fatty liver because on the opposed phase, they have a low signal throughout the liver. They've got a big left lobe. They are fibrotic, and you've got this nodule here, which doesn't have anywhere near as much background fat within it. And that's also a good sign that you're dealing with an HCC, because you think you've got a fatty liver largely because of diet and toxins coming in through your portal vein. So bits of liver that get more portal venous blood are going to be involved to a greater extent. Given the HCC has predominantly an arterial input, it's going to be relatively spared from a lot of those toxins, and so it won't have steatosis to the same degree. So I'm always concerned about a fatty liver that has a nodule within that is protected from the steatosis, and that was also an HCC. Low-grade dysplastic nodules, you don't see these on the dynamic images at all. You don't see them on the diffusion, but you will pick them up on the hepatobiliary phase, and they take up contrast to be hyper-enhancing on that hepatobiliary phase. Low-grade dysplastic nodules, it's really part of fibrosis, and you don't need to worry about those. The guidelines, and I think this set of guidelines is really well worth knowing. It makes your life much easier because it makes life simple. So there's heaps of guidelines out there for HCC surveillance and diagnosis. These are the ones from the American Association of Study of Liver Diseases. It's very similar to the ones that were published by GISA. It's very similar to the Japanese guidelines. It's all really based around having a patient with a ultrasound screening new focal liver lesion. And whenever one of the sonographers says, I've got a new liver lesion, the first question I ask is, how big is it? Because if it's under 10 millimeters, all you need to do is repeat the ultrasound in 3 months' time. And the reason that you do that is a lesion that is sub-centimeter, you're very, very unlikely to show arterialization and washout, whether you do a CT or an MRI. Even if you give ultrasound contrast, you might show that it's arterialized, but you're not really going to be able to give a definitive answer. And so instead of putting them through that test, you just repeat the ultrasound in 3 months and see what happens. And if it gets bigger, then you can escalate to other imaging. If it stays the same, you can continue to watch it. And groups have looked at what happens to patients when you take this approach, and not a single patient is upstaged. These are very early tumors, and by delaying the diagnosis by 3 months, you don't actually change their management or their prognosis at all. One of the problems with doing cross-sectional imaging in these patients is part of fibrosis is the liver develops multiple shunts. And so chances are you'll find an arterialized lesion somewhere else that you then have to chase up, and the patient just gets into this massive spiral of investigation. So sub-centimeter, repeat the ultrasound in 3 months. If it's over 10 millimeters, then do cross-sectional imaging. It can be either CT or MRI, depending on whatever you have available. If you can give a definitive diagnosis of arterialization and washout, you can call it an HCC. If you can give a definitive benign diagnosis, such as hemangioma, go for it. If you can't, you do whatever modality that you haven't done. And if that still doesn't give you an answer, you just do a biopsy. So it is really very simple. You just need to remember 10 millimeters. If it's over, do imaging. If I can't work it out on the imaging, do a biopsy. So this is the approach I have for chronic liver disease. And I think these are most of the combinations you're likely to come across. So arterial phase hyperenhancement and washout, it's an HCC. Those patients should be sent to an MDM. If the vein is involved, it's usually going to be the portal vein, it's an HCC, send them to an MDM. Arterial phase hyperenhancement, fading, no washout, but hypo-intense in the hepatobiliary phase, that's probably either an early HCC or will become an HCC. So again, send them on to the MDM. Then there's a group of patients who have a lesion that is hyperintense on the DWI, hypointense on the hepatobiliary phase, but you don't see it at all on the arterial dominant or the portal venous phase. Many of those are going to go on to become an HCC. So they need to be followed quite closely. It's something like 70% of them will be an HCC within around 2 years. So watch them or send them on to the MDM. Ideally, it's the sort of thing you can watch with ultrasound as well. One thing I always tell our registrars is if a patient's got chronic liver disease and a focal lesion over 30 millimeters, really doesn't matter what it looks like, chances are it's an HCC. And then remember screening, if it's under 10 millimeters, just repeat the ultrasound. Okay, so this is really designed just to have a high sensitivity for HCC detection. The reality is HCC is so common and so important that if you call it and say it's suspicious, no one is ever going to criticize you because it's an important diagnosis to make, and chances are you are right. So if we move on to patients who have no known chronic liver disease, we know that lesion detection improves with MR using hepatobiliary phase and DWI. Lesion detection improves with good quality CT and good quality ultrasound. So really we're going to focus on characterization. So again, with step 1, choose your contrast. Step 2, know your background liver. So then step 3 is, does the lesion have arterial phase hyperenhancement? And if it does, it's relatively short list, and I love lists. So I think it's an FNH, an adenoma, an HCC is on the list, hypervascular metastasis, flash-filling hemangioma, or a vascular anomaly. They're going to be the majority of arterial phase hyperenhancing lesions that you come across. So I always think for things like hypervascular metastases, have a look at the pancreas. Do they have any evidence of a neuroendocrine tumor? Have a look in the mesentery, any evidence of a carcinoid. In a younger population, adenoma is going to be up there with the differential. FNH is far more common than adenoma. So whenever you're thinking adenoma, do have FNH in the back of your mind. The reason that HCC has to be on this list still is because around 10% of HCC occurs in patients with no fibrosis, particularly those who have Hep B. And it's a pet hate of mine when I'm giving a tute or to a registrar or in an exam when the candidate says, I would inquire if the patient has chronic liver disease, because I think that shows a lack of understanding of what we're actually dealing with. In Australia, around 40% of patients who are diagnosed with an HCC do not know they have chronic liver disease. So you cannot rely on the clinical notes or the patient to give you that information. So if you're waiting for your differential, if it needs that information, you've missed the point. You've got to have it in the back of your mind at all times. So in this lesion, step 4, does the lesion wash out? So we're dealing with an arterialized lesion, so it's hypointense in the pre-contrast, arterialized, it washes out, it's got a capsule, it's dark in the hepatobiliary phase. This is an HCC in a patient who did not know they had chronic liver disease. Capsule is really important, washout is really important. Just remember, HCC is very common, and there's been multiple patients who call it an HCC, and then when someone takes a history, you realize they do drink more than they should, or they've had metabolic syndrome or a wild youth. Step 5 is really, what does it look like on the hepatobiliary phase and the T2? And these do have a lot of useful information. So this picture here in the middle, very hyperintense lesion. It's almost as bright as CSF. This was a hemangioma. So it does have this little band or almost scar-like area within it, but it's definitely a hemangioma. This lesion I think is quite useful. You can see that this has some hyperintense signal around the periphery, but the center of it is isointense to the background liver. It's relatively dark on T2. And so it's almost an atoll. And often when people talk about atoll and liver imaging, it makes you think of adenoma. But I think this is a really useful sign for cholangiocarcinoma, because you get tumor around the outside and you're getting fibrosis in the middle, and the fibrosis does have lower signal intensity. And this also has capsular retraction, which again is a good sign for being a fibrotic tumor. The majority of lesions I've seen over the years that cause capsular retraction are either cholangiocarcinoma or metastases from breast cancer. This one, hyperintense in the hepatobiliary phase, that was a focal nodular hyperplasia. These two pictures go together, and this was actually an adenoma. So it's only mildly hyperintense on the T2. It's got some very irregular, slightly increased signal within, but it was dark on that hepatobiliary phase. So that was an adenoma. So using the hepatobiliary and the T2 to get you a bit more diagnostic information. So given just how common FNH is, I thought I'd talk about it a bit. It is the second most common benign liver tumor after hemangioma. These are usually incidental findings, and it's not uncommon that they'll turn up after a patient's already had 5 or 6 CTs. So we do our CT chests now as a portal venous phase because we think it gives you a better assessment of the pleura. And so every now and then we'll be following a cancer patient. They'll have a scan done for another indication, get an arterial component, and you see something in the liver that's really been there all the time. We've just never seen it. But that does need to go on for further characterization. So they're very, very common. They don't need treatment. And so because of that, we have to give an accurate non-invasive diagnosis so we can reassure the patient and keep them away from unnecessary intervention. the size is really quite variable, and these can actually grow with time. They can also regress a bit. They're really normal hepatocytes, and they grow because of a disturbance to the vascularity of the liver. So they do have increased rates in conditions such as Osler-Weber, and they have a high rate of coexistence with hemangiomas. So it's really a response to distorted vascularity. And there's 6 typical features. You don't have to have all of these, but the more you've got, the more confident you can be. And you can work out most of them just by thinking about first principles, because these really are normal hepatocytes. So of course they will be isointense on T1 and T2, caveat being that is only compared to a normal liver. So if you've got a fatty liver and you're doing fat suppressed T2 images, the background liver is going to become pathologically dark because of the fat, and these lesions will look bright. And in those cases, you need to compare it to something like the spleen to say, yeah, that probably is where the liver should be if it wasn't fatty. So it's recognizing again, you've got that abnormal background. They're well organized cells, so they're homogeneous. Everyone knows about the T2 hyperintense scar. The reality is FNH under 30 millimeters, only around 1/3 of them have a scar that you can see. As they get bigger, it can actually have a couple of scars. So these are arterially hyperenhancing, and they tend to fade into the portal venous phase. That scar can enhance later on, and they don't have a capsule, which is a really good differentiating feature from an HCC. So this is your typical FNH. You can see isointense to a background normal liver. You can see it's displacing all of these vessels because it is growing. It's got a hyperintense T2 scar, isointense on the pre-contrast, homogeneous enhancement, no washout at all. And this is the later phase. You can see that scar is starting to enhance. You won't get the delayed phase scar enhancement if you give Primavist. And that's because these lesions become so bright because they take up the contrast and then struggle to get rid of it, that the scar always looks relatively dark. There are multiple enhancement patterns that you can get with FNH, and it's important to recognize these so you don't get concerned. So here we've got the arterial phase at the top and the corresponding hepatobiliary phase at the bottom. You can see this is slightly hyperintense compared to background liver, dark scar. This one has more of that peripheral hyperenhancement and then some heterogeneous but increased signal intensity centrally. And you can even get these ring enhancing lesions like this one. And the other one is where it is just isointense to the background liver. One pattern I've seen that's caused problems over the years is this one, where you have this low signal area in the hepatobiliary phase, and because of that, it's mistaken for being either an adenoma, a MET, or an HCC. But this is in the arterial phase, and it's really important to recognize that the lesion here is significantly smaller than the lesion here. And so there's part of the lesion around the peripheral aspect that is there, but we're just not appreciating it because it is isointense to the background liver. So this is just a variant of the ring enhancing lesion, where instead of it being hyper enhancing ring, it's just an iso enhancing ring. So if in doubt, measure on the hepatobiliary phase and make sure it is the same size in the arterial phase and you're not missing part of the lesion. Adenomas are relatively uncommon. These are often quite irregular. They can have fat, glycogen, or hemorrhage, so they may have increased signal on T1. They can look quite ugly and irregular on ultrasound and CT. And we like to think that MRI is a wonderful test, but the reality is we can't differentiate FNH from adenoma in around 40% of cases if you use standard contrast agents. And it really is important to make a distinction because adenomas get treatment, and that treatment might be dietary, it might be stopping the oral contraceptive pill, or it could be interventional. But we do really want to make the diagnosis. There are multiple subtypes. You don't really need to know this, you just need to know that different subtypes do exist. The useful bits really come down to some subtypes have more bleeding risk than others. So the inflammatory ones in particular do. and they're also associated with the oral contraceptive pill and the metabolic syndrome. Beta-catenin, exon 3, more likely in men, and they have high HCC rates. Adenomas in men are exceedingly rare, but when present, they have to be treated just because of the malignant degeneration rate. And also they tend to get treated because we don't think of them as being adenomas, call them something else, and they get cut out anyway. The HNF alpha 1 inactivated ones, they're the steatotic adenomas, and you can be quite confident with those because they just lose signal throughout on the opposed phase T1. They may not even have much in the way of arterial hyperenhancement. So it's the opposed phase that really helps you with these, and they have a relatively indolent course anyway. And the inflammatory ones, these can cause some problems. They tend to be a bit more irregular on the T2, but they can also retain contrast in the hepatobiliary phase. So this is the dream patient for anyone who has to give a talk on liver imaging, because they have a liver that is iso-intense on the pre-contrast and they've got a couple of liver lesions. You've got this one that is arterially hyperenhancing. This one is arterially hyperenhancing, but not quite to the same degree. The one on the right is really homogeneous. This is a bit more irregular. This is just the spleen back here. On the T2, this homogeneous lesion is iso-intense to a normal background liver. Makes perfect sense for that to be an FNH, being normal hepatocytes. This one has increased signal within, so they are not quite normal hepatocytes, and that has to be a red flag. On the hepatobiliary phase, the homogeneous lesion retains contrast to be bright, and that's an FNH. This one loses signal, and that was an inflammatory adenoma. So when people started giving talks about Primavist, used to just talk about looking at the arterial phase and then looking at the hepatobiliary phase to make the distinction between basically FNH and everything else. These days, I won't call an FNH unless I've had a good close look at the T2. And if it's irregular on the T2 or hyperintense on the T2, really start to wonder, am I dealing with an adenoma? So moving on now, we're on to step 6, and this is one that is also frequently overlooked, and it is the answer outside the liver. So this large necrotic looking irregular liver lesion, it's got diffusion restriction, and you can see they've got an apple core lesion in their sigmoid colon. The ones I've seen missed most often are sigmoid colon, like colonic tumors. So that's not the sigmoid colon, that was the splenic flexure. And pancreatic tumors. I did miss one the other day with capsular retraction. I called it a cholangiocarcinoma, and I missed it in the film bag. The patient had a mammo and had had a previous mastectomy, and it turned out to be a breast cancer. So is the answer outside the liver? That can get you out of a lot of trouble. Step 7, I think, is probably the most important one, and I cannot emphasize this enough. It's really important to keep things simple. And at the end of the day, there's probably only 3 categories I care about. It's malignant, I know what this is. Benign, I know what it is. Or indeterminate. And if it's indeterminate, I put it into a subcategory of, I'm worried enough about this that I think we should biopsy it. Or I reckon this is towards the benign end of the spectrum, let's watch it. And I really think that if we simplify it like that, you can always put out a sensible report. When I give tutes to registrars, they'll often give a differential list to any liver lesion that you show, and it frequently crosses benign and malignant. And when you say to them, what's your gut tell you? Does it look ugly? They're incredibly accurate at saying, yeah, this looks bad. And I think we've all seen enough that we can recognize ugly. And if in doubt, that is a really good question. Does this look ugly? If it does, chances are it's malignant. Trust your instincts. They're the ones you're going to go on and do the biopsy on. So I think it is really useful. There have been times when I've done things like subtraction imaging to try to work out what a liver lesion is. I've even put ROIs on things with MR. I've always found putting a ROI on something useful, not for the ROI itself, because I always delete it and ignore it. But for me, it is a red flag that I've lost sight of the big picture of what's happening in this patient. if my diagnosis is going to hinge on a density measurement or an intensity measurement, I've missed the point, and I need to go back to these simple steps, because at those points you usually think of something that's weird and wonderful, and don't. I've made a lot of mistakes over the years. I've never been criticized for calling something a common condition that has turned out to be wrong. So I called an HCC 2 years ago, they resected it, and it was a hepatic epithelioid angiomyolipoma. I don't lose sleep over that. It needed to come out anyway. If I'd called it an epithelioid angiomyolipoma and they left it in and it turned out to be an HCC, I would feel like an idiot. So keep it simple, put it in these categories, and particularly if you're in doubt about what it is, really stick with what's common. So these are the steps. There's only 7 steps you really need to know, and I thought we'd see if we could put them into practice. So I've got a couple of examples to go through for WTF liver lesions. So know your background liver. We've decided to give Primavist for this patient. The opposed phase is here, the in phase is there. There's no significant dropout. So they're not steatotic. The margin of the liver is relatively smooth. We are incredibly insensitive for detecting fibrosis. They can have a perfectly normal looking liver and be cirrhotic. The distinction between macro and micronodular cirrhosis is 3 millimeters. So if they're a micronodular cirrhotic, it's beyond our resolution. So you can never have HCC off the table. But this does look like a relatively normal looking liver, and this was a young patient. The T2, it's really quite irregular. I think the background signal within this lesion is a bit brighter than the background liver. You've got this quite bright bit there, potentially an irregular looking scar. It's arterially hyper-enhancing, but again, it's a bit irregular. It's not super homogeneous. It's not washing out at all, and it retains contrast in the hepatobiliary phase. So previously I would have just gone arterial hyper-enhancing, hepatobiliary phase, ISO to hyper-enhancing, this is an FNH. But it doesn't make sense in this case because the background lesion is brighter than the liver, and the liver is normal. So this cannot be normal hepatocytes. So we called this one an adenoma, suggested a biopsy. The surgeons didn't do a biopsy, they just cut it out. We had a nervous wait and it came back as an inflammatory adenoma. So the T2 is really worth looking at and inspecting and comparing that to the background liver. FNH is usually a pretty homogeneous looking lesion. This was on the MDM a couple of months ago now. So you've got this irregular lesion filling the posterior right. It's got some really hyper-intense signal within it here. If we're looking at the background liver, that on the opposed phase, there's no significant loss of signal to suggest a steatotic liver. Again, really smooth looking capsule. There was no caudate enlargement. But you've got a big lesion, it's got bright bits in it, and on the opposed phase, it's also got some signal loss in parts of it. So it must have fat within it. It's got bright bits within it. So is that blood or glycogen? It's arterially hyper-enhancing, really quite irregular though. This bit has vivid enhancement. This was an aneurysm within the lesion with clot sitting at the dome. It does wash out because it's darker than the background liver in the portal venous phase. You get the impression that there is a capsule around it. It's almost iso-intense, the background liver on the T2, and you can see that laminated clot sitting there. So it's arterially hyper-enhancing. It washes out. So on that, we can call it an HCC. But we don't even know if this patient has chronic liver disease. It's got a capsule, which is supportive of an HCC. It's got hemorrhage, it's got fat. So called this an HCC, biopsied HCC, and went on to get a resection. So sticking to the simple rules, you can come up with a reasonably sensible diagnosis. And this patient was given his diagnosis of chronic liver disease after the HCC was biopsied. This was a young patient. He was 40. He was in our drug and alcohol bit trying to detox, and he had a 28mm focal liver lesion seen on a screening ultrasound. He had significant background steatosis from his alcohol, and you can see he's got substantial signal loss within his liver here on the opposed phase, and this was the nodule that we could see on ultrasound. It was subcapsular. It's a little bit brighter than the background liver, but it probably doesn't have fat within it. So again, a nodule without fat I am concerned about, because it must be getting more arterial inflow than portal venous inflow. It has a lot of arterial hyperenhancement. It doesn't wash out, and it retains contrast in the hepatobiliary phase in almost a ring type pattern. And on the T2, it's got this central really bright bit, and the peripheral aspect is really quite, it's almost iso-intense, the background liver. So before he got the MR during his screening ultrasound, we gave him ultrasound contrast, and it had rapid arterialization, and it washed out to a mild degree in the late phase. So on ultrasound, I told him he had an HCC. We did this, and I was no longer convinced it was an HCC. My gut told me that it was, because it was big, he was at risk, and I just assumed it was a well-differentiated one. But it said, I think we should biopsy it. I'm not happy to give a definitive answer. So we biopsied this, and the answer came back as an HCC. The patient then went on to a resection, had the entire thing cut out, and the pathologist then examined it, and the final diagnosis was an FNH. So we make mistakes, they make mistakes. All you can do really is follow the rules. You're not going to get it right every single time. Stick common, follow the rules. You'll always say something sensible. This was another patient from the MDM only a few weeks ago, 50-year-old, otherwise well. He does have significant steatosis in that background liver. No known chronic liver disease other than steatosis, but he's got a reasonable amount of signal loss, smooth margins, this dark lesion here, but that really fits because this is a non-fat saturated image. So this liver here is pathologically bright. So this may be normal liver signal for him. You can see it on the pre-contrast. It's got some irregular peripheral arterialization around it. A lot of breathing artifact with Primavist. It is something that relates often to the speed you inject with. And in cases where the arterial phase hyperenhancement is really critical, you can refer to the CT, because if they're arterialized on the CT, you don't need the arterial phase on the MR. They will be arterialized. You've already demonstrated that vascular inflow. By the time you get to the portal venous phase, it's starting to wash out, and it does have this look of a capsule around it. And in the hepatobiliary phase, it was dark. Remember to always look at the T2, because I think the critical thing for this diagnosis is here, where the liver lesion, it's only slightly brighter compared to the background liver, but it's got these bright branching things within it. So we decided that they were bile ducts. And if you think about first principles, a tumor should destroy everything there. So cholangiocarcinomas do cause bile duct dilatation, but it's in the peripheral aspect of the liver that's upstream to them. They shouldn't have ductal dilatation within them, because they should have been obliterated. So in the MDM, we put this into that third category of this is indeterminate. I have absolutely no idea what it is, but we should biopsy it. And on biopsy, it came back as caseating and non-caseating granulomas, and it turned out to be brucellosis, which is cat scratch fever, and that is absolutely everything I know about cat scratch fever. But it does show that the rules work. So follow these, choose your contrast, know your background liver. Is it arterially phase hyperenhancing? Does it wash out? Really have a good look at your T2 and your hepatobiliary. Is the answer outside the liver? And always keep it simple. I think we've got time for questions.
Thanks very much, Tom, for that excellent lecture. we have quite a few questions have come through. Let me start off now. I'm sure, Tom, you'll be happy to take any general questions as well in terms of liver imaging. And so please put your questions in there. This is a really good opportunity to ask Tom whatever you would like about liver imaging. So the first question we have, I think I read this as when no injected liver MRI is enough. So I presume they're asking, do you ever do any MRI studies without contrast?
By the time we put them on the MR, I would always give contrast if I can. The times that we don't give contrast are when we're looking at a patient really for screening them for HCC. So patients who you don't get great views of their liver for one reason or another can have an unenhanced MR. So diffusion is very good, T2 is very good. I know some in the States, they will often give Primavist as well, and then sort of do a diffusion T2 and then look at the hepatobiliary phase. That's too expensive for us to do. So we just do DWI and T2 in that setting. We did a study in that a few years ago, and it did prove to be as accurate as ultrasound. I think we picked in that cohort 7 HCCs on ultrasound screening, and there was 6 on the MR. That is pretty well the only indication I wouldn't give contrast for, though.
All right, we have another question here. So is Garadobopter a multi-Hance? Is it a good surrogate for Primavist?
It's something that I have absolutely no experience with. So Primavist has 50% hepatic excretion, whereas Bopter's about 4%. So it does interfere with your workflow because you've got to get the patient back after a couple of hours, whereas Primavist, you can scan them all in one session. One of the main advantages, though, is you probably do get better dynamic phases and you don't get the same dyspnea in the arterial phase. And if you're organised, you can also look at the study at the time, and frequently you don't need to bring the patient back. But as I said, it's not something I've had any real experience with. I don't think we've been able to get it in Australia for 5 years or so, so I don't see myself getting experience. But I think pretty well, if you can get it, it would be good, but just stay simple. I think one of the things with imaging in particular, and I think all of medicine these days, is our technology is getting so good, we're becoming dependent on it, and we're forgetting some of those simple first principles, which are far more valuable.
We used to use quite a lot of multi-Hance, as you say, about 4 years ago. And what we found was that that was actually very sensitive in differentiating FNH from adenoma. And it also had the benefit that you talked about. The problem with Primavist is that it loses its extracellular properties very early on. But because the multi-Hance is more of a gadolinium base, we could do that scanning for the hemangiomas as well. So it was actually very useful for FNH versus adenoma and for looking for hemangiomas, but for everything else, it really wasn't that good. But I think we've lost that because I don't think they're actually manufacturing that anymore. I think this question has come from France. The person who asked it said bonjour, so I presume they're from France. Could you just put in the chat box if you still have access to multi-Hance in Europe? That would be really useful to know. The next question, Tom, is I think you made reference to flip angles. The question is, were your flip angles based on a 1.5 Tesla or a 3 Tesla?
I'm about as good with MR physics as I am with technology, and I did start this meeting 15 minutes early by clicking the wrong button. I believe our flip angle of 10 is for both 1.5 and 3 T. The reality is, in our hospital, we've got 3 MRs, and I don't get to do any on the 3T these days. So yeah, 35 on the 1.5T, but we had been fiddling with it on the 3T, but that was quite a while ago, so I can't quite remember. It does give you a very dramatic improvement in the contrast enhancement though, and it only takes about an extra 20 to 25 seconds to acquire, so I encourage you all to give it a go, have a look at it, decide if you like it, and if you do, keep it. Particularly those chronic liver disease patients, Child-Pugh B and Child-Pugh C, who don't take up their liver doesn't take up much of the contrast, it can help.
Just to follow up on the previous question, yes, that question did come from France. And yes, they do have access to multi-Hans, which is interesting because we don't have access to that anymore in Australia. So different parts of the world seem to be working with different things. We have another question that's come through. Now, I'm sorry, I apologize to the person who sent this through Mera. The question reads, is a focal fatty lesion, I think this reads, is a focal fatty lesion greater than 10 millimeters of significance? Now, that's a very general, broad question there, Tom. So, not sure if how you...
I think look, I mean, this does come up a lot. I think if you've got a good going fatty liver and the focal fatty sparing is in a characteristic location, so typically adjacent to the gallbladder bed or the porta hepatis, I like to have a really good look at the echo texture, because the echogenicity might be different, but the echo texture between the focal fatty sparing and the fatty liver should be the same. And because it always classically runs up to the capsule, there should be absolutely no distortion of the capsule, no volume loss and no mass effect. And if it fulfills that same echo texture, no mass effect, I'm happy to call it focal fatty sparing. The reality is there's so many forms of focal fatty sparing. It can be mass-like and quite irregular. I think if there's anything that concerns you, then you go on and do some further imaging. You're really thinking, I mean, screening ultrasound in particular, you're there to have a high sensitivity. There's a lot of people who still do screening ultrasounds and they look at the kidneys and the gallbladder, and all those things are unnecessary. We are much better off spending extra time looking at the liver itself, because we don't do well with small lesions, and they're the ones we really do need to detect. So I think, yeah, for focal fatty liver, same echo texture, no mass effect, classic position, happy to call. The other forms, I think, go on and do something else to reassure yourself that it is fat.
Next question, Primavist loses gadolinium properties over time. Why not always start with gadolinium as an initial contrast selection to see GAD behavior in a lesion?
So assume is that as in not use Primavist early on and get them back? A lot of it does come down to logistics, trying to get the patient in and out in one go. I also think that the diagnostic information you get out of Primavist can be so useful by allowing you to see how those cells are functioning. I think particularly in the chronic liver disease patients, where you do get those hypoenhancing lesions that you know are likely to progress, it does help the referring doctor reinforce to that patient that it really is important they keep turning up for their ultrasound surveillance and screening. They're often a cohort of patients who are fairly unreliable. So I think it does give you a lot more information. It's a lot easier than getting a patient back twice. No one likes to be recalled for another test. That causes a lot of anxiety, stress, and particularly MR in most places is such a finite resource. We can't afford to do a study twice. I hope that answers it.
Thank you. So further follow-up of that original question regarding multi-Hans, we don't have Primavist. So I guess, once again, different parts of the world with different tools. The next question, so if a lesion, so somebody asked a question there about differentiating a lesion from fatty infiltration. If you don't mind, please rewriting that question in. How would you report follow-up incidental sub-centimeter hypodense lesions very commonly seen on portal venous phase CT of the abdomen? Would you follow up with CT in 3 months?
Look, I must admit, I tend to under-investigate often. I say, particularly if you've got a patient who does not have any evidence of chronic liver disease and it's just a small focal liver lesion. There was a study done in the 80s that I think it looked at around 3,000 patients who had known extrahepatic malignancies, and about 20% of them had focal liver lesions less than 20 millimeters on CT. And so out of that 20%, something like 80% of those lesions turned out to be benign. And that was on a single slice CT. I think now that we CT everyone with multi-phase imaging, and our imaging is getting so good, we're seeing tiny lesions all the time. And I think the vast majority of them are biliary hematomas and tiny little cysts. And I know it's an argument I often have with colleagues and registrars who recommend doing an ultrasound for these things. And often in a big patient, a small lesion, you can never see it anyway. So I think frequently your pretest probability is relatively low that it's anything nasty. And I will often just say, call it benign based upon that. Obviously a patient who has a known tumor and I've got no previous imaging to compare to, I will generally recommend doing an MRI. If their tumor is known to be resectable, and this would potentially be their only site of metastatic disease, that comes up occasionally in the MDMs, I still recommend that they just cut the primary tumor out and we watch what's happening in the liver rather than losing time investigating something that will just delay definitive treatment for them, because I think they frequently do turn out to be nothing.
Okay, this is another question from Mary. Are fatty sparing lesions hypoechoic or hyperechoic on ultrasound?
So fat on ultrasound is hyperechoic, so focal fatty sparing is relatively hypoechoic. That should be darker.
I'm not sure if I understand this question, but how do we differentiate HCC? Oh, sorry, the question is, how do we differentiate HCC? Is it from or with fatty sparing? It's written as, how do we differentiate HCC with fatty sparing? Can I get you just, unless you understand that, Tom, I'll get them to elaborate on that question.
Yeah, I'm not quite sure with that one. I mean, remember, for HCC, you have to have arterialization and washout. And focal fatty sparing and focal fatty infiltration has exactly the same blood supply as the rest of the liver. So it does not enhance any differently, does not behave differently. So you shouldn't be calling an HCC unless it's arterialized and washout. And focal fatty sparing and infiltration will never do that. Another sign can also be vessels and things running through focal fatty sparing and infiltration without any distortion. And again, that implies you've got no mass effect to that lesion, and it is a sign that it is fat.
Do you use the term too small to characterize in your reporting?
Yes, occasionally, and I'll stick it in the, I tend to hide that in the body of the report with the idea that no one's ever going to read it. Because I suppose I'm a big believer in that we're radiologists, we are doctors, and we do need to take responsibility for the patient and our reports. And I think a lot of our reports cause a lot of anxiety. And it's really coming back to every time I'm uncertain about something, I just ask, if I call this, how is it going to hurt the patient versus how is it going to hurt them if I ignore it? And it's amazing how often I think by ignoring something, it's actually in the patient's best interest. Referring doctors these days generally feel obliged to follow something up if we call it. And I've seen a patient before who had a resectable pancreatic CA and a benign liver lesion, and they spent so long investigating that liver lesion that the pancreatic CA progressed and she was unresectable. And I think that's a disaster that we have contributed to. So I accept I'm going to make mistakes from time to time. but I try to be definitive because your referring doctor wants a definitive report. And that's why I try to keep it simple. Malignant, yes. Benign, yes. Indeterminate, let's do something else, or just, just ignore it.
We have this other questions coming from Oais Mohammed. What's the size of liver lesions that are hypoechoic on ultrasound that you should follow up, and how much size? So basically, what size of hypoechoic liver lesions on ultrasound should we follow up with triphasic CT?
So I would not do a triphasic CT or MR unless the lesion was over 10 millimeters. When you start doing pure targeted liver ultrasounds in your HCC screening population, you start to see a lot more lesions. Often these are patients who normally will just get a hepatic survey done with a curved array. When you pull a high frequency probe out and put that on, you see tiny little echogenic lesions throughout their liver frequently, which is really just part of their regenerative nodular process. We can never follow all of those. So my rule of thumb is over 10 millimeters cross-sectional imaging. Under 10 millimeters, if you can see it with a curved probe, follow-up ultrasound in 3 months. High frequency ultrasound, if you're seeing lots of little lesions, they're probably regenerative nodules and they can have an ultrasound in 6 months.
Okay, so if you have any other questions, please use the opportunity now to type them in. Let's give it 30 seconds or more to see if there's any further questions. Just while we're waiting, Tom, I might ask you, you mentioned the 3 different types of adenomas. Do you, when you're reporting, do you actually try and classify or differentiate the 3 types, or will you just give it a general adenoma description?
I generally just give an adenoma description unless I think it's inflammatory, which is the ones that have the higher T2 signal. The other ones, yeah, just call them an adenoma.
We have another question that's come through. What features make you content to cause cirrhosis? Also, how reliable is a dilated portal vein for portal hypertension?
I don't put much emphasis on the portal vein size at all for any modality. I think it really, part of it depends on, are they postprandial, have they valsalvage, so many other factors. I do have a close look for any recanalization of the paraumbilical vein, splenic size, early signs of prominent vessels around that splenic hilum. Splenic size as well, you've got to factor that in with the patient size. Often a 14 centimeter spleen is completely normal in a 6-foot patient. So you do need to have that sort of information. So portal vein, I have no emphasis or weight on at all. For chronic liver disease, unless I can be convinced I can see nodularity or caudate enlargement or hypertrophy of the left lobe, I raise it, and I'll often say, assessment of risk factors is worth it. And obviously in those patients, any lesion you see could potentially be an HCC, but I don't think a portal vein measurement will push one way or the other. I think measuring things is a very musculoskeletal radiology thing to do, and I don't understand MSK.
Okay, we'll probably just take the last couple of questions here. How do we differentiate HCC from regenerative nodules on MRI?
So a regenerative nodule, you really shouldn't see because you've got to remember that cirrhosis affects the entire liver. So by the time you're cirrhotic, your entire liver is regenerative nodules. So they are all going to be iso-intense to every other regenerative nodule on T1, T2. They're not going to be arterially hyper-enhancing and they're not going to wash out. So you're not going to see them in the dynamic, you're not going to see them on the diffusion, and you won't see them on the hepatobiliary phase. Often it's a hepatobiliary phase that tells you they're a cirrhotic patient because you can get hyperintense nodules, which are those low-grade dysplastic ones, and you can appreciate some of the fibrous bands. So that can be quite a good sequence to look at to say, yes, they're fibrotic, but regenerative nodules don't enhance. HCC, arterial hyperenhancement, and then washes out. So that's the easiest way. And you can see HCC on the DWI and the T2.
Okay, thank you. Okay, so I think that's all the questions come through. There are several thank yous coming through. So we might end it on that note. So once again, Tom, thanks for an absolutely excellent lecture. I think you've given a really thorough and succinct way of approaching liver lesions and the liver in general. And this is a topic which, being to a lot of the developing nations that we assist and the nations that we assist, is a very common problem. And as you indicated at the start of your lecture, it's a growing problem, not just in developed nations, but also in developing nations. So it's a really important topic to have. So thank you very much for that excellent session. I note you've put up the ARGANS meeting for next year. So I gather that's in Sydney?
Yeah, that's in Sydney, face to face, and we'd love to have as many people as possible. We always have some good speakers, and there's fantastic people on liver, prostate. It's always a very good meeting. So please attend, and thanks for having me.
Terrific. So I'd like to just end with a little bit of housekeeping for what's coming up. So tomorrow evening we have the rabbit session, so the imaging technology session. So as you know, the two sessions are interchangeable in terms of attendance, and that will be on traumatic injuries, X-ray with CT correlation. And then on the for the next webinar, which will be held on the 17th of November, that will be given by our first colleague in Germany. It will be Dr. Rüdiger von Kummer, and Rüdiger will be giving a talk on stroke. And so that should be another excellent session following on from this one tonight. And finally, on the 27th of November, we'll be having our last day virtual conference, which will be our mammography program called Impact. So we have 3 excellent sessions coming up in the next month or so. So on that note, once again, I'd like to thank Tom for an excellent lecture. Thank you all for attending, and stay safe. And we look forward to seeing you tomorrow night and during the course of November for the further sessions. Good night, everybody.